Hello, everyone. Thanks for joining us for today's event today, Keeping Care Local, Federal Policies to Support Rural Hospitals. I'm Dr. Anand Parekh, Chief Medical Advisor at the Bipartisan Policy Center, and I'd like to welcome all of you. I'd like to acknowledge at the outset both Emma Shefford and Maya Sandilow for their leadership of BPC's rural health portfolio. Most of you know of BPC. We're a nonprofit organization in Washington, D.C. that strives to take the best ideas from both sides to promote health, security, and opportunity. Our health program is focused on advancing bipartisan solutions to build a more cost-effective, evidence-based healthcare system and to improve overall population health. This includes strengthening and sustaining Medicare and Medicaid, accelerating the transition to value-based care, addressing inefficiencies and misaligned incentives, and responsibly leveraging technology and innovation. For nearly a decade, BPC's health team has developed bipartisan solutions to help rural communities access quality care, our topic today. Nearly 60 million Americans, almost 1 in 5, live in rural communities and depend on rural hospitals for healthcare. These facilities face growing financial strain, and in 2025, several key Medicare programs that provide critical support are set to expire. At the same time, rural hospitals are facing new pressures tied to rising participation in Medicare Advantage. This past October, BPC released a 2-year progress report on the Rural Emergency Hospital REH model, a new provider type designed to help small hospitals stay open and continue to provide emergency care. The model shows promise, but hospital leaders suggest areas for improvement to ensure smoother implementation. And last week, BPC released a report on Medicare's rural hospital designations, which provide targeted financial support to small, geographically isolated hospitals. These programs, including critical access hospitals, sole community hospitals, and Medicare dependent hospitals, have been in place for decades, but the rules governing them have largely been stagnant. BPC's recent recommendations include allowing state flexibility in determining critical access hospital participation, stabilizing rural prospective payment system hospitals, improving the rural experience in the MA program, and strengthening rural emergency medical services. Today's panel discussion will touch on some of these issues. The reality is that rural systems can be fragile. Many rural hospitals operate on thin margins, and without adequate federal support, they risk closure, leaving communities without access to care. And that's why bipartisan solutions are more important now than ever. And finally, while BPC's latest reports evaluate how Medicare payment policies affect rural hospitals, it's important to recognize that Medicaid also plays a crucial role in the financial health of many rural hospitals. Reductions in any type of payment, Medicare or Medicaid, can introduce significant uncertainty and put access to rural health services at risk. In fact, rural hospitals are frequent to note that the patchwork financing system itself can create confusion. In the future, policymakers should work towards simplifying these payment structures to create long-term, sustainable rural healthcare access. To discuss all of these issues, I'll now turn it over to our panel of experts. Leading our panel today is Senior Correspondent for KFF Health News, Sarah Jane Tribble. The panelists joining her are Carrie Cochran-McLean, the Chief Policy Officer for the National Rural Health Association, John Henderson, the CEO of the Texas Organization of Rural and Community Hospitals, and Mark Holmes, the Director of North Carolina's Rural Health Research and Policy Analysis Center. With that, Sarah, I'll turn it over to you. Thank you.
And thank you all for being here today. I'm excited to moderate this event, and I think it's probably the reason everybody has shown up today. As a reporter who's covered rural health for years, I know that Carrie, Mark, and John are some of the most connected, tapped-in rural health experts in America. So we're going to jump right in, and we're going to talk about BPC's latest report on sustaining rural hospital access and bring in their expertise on what is happening on the ground here in DC when it comes to funding and taking care of patients. So we've done the formal introductions, and I actually am going to start off turning to Mark Holmes with the Shep Center, because everybody starts off reporting about rural health, turning to Mark and the Shep Center, because they have some of the best data out there. Mark, could you describe the current landscape of rural hospital designations nationwide, and also the number of closings we're seeing by designations such as critical access in the past few years.
Thanks, Sarah. Appreciate that kind note to start us off. So, yeah, let's focus on rural hospitals because that's the talk of today. And so, we have a number of different, as the report mentions, and as we started in the background, a number of different designations for rural hospitals across the country. Whereas, like 70% of urban hospitals are classified as prospective payment system, there are a number of different designations that are provided or allowed for rural hospitals. And this recognizes the unique circumstances of the rural environment. Rural hospitals often have lower volume, they're more isolated, and there's a number of other challenges. And over the past 30, 40 years, Congress has created a number of these special designations. The largest bucket of these 2,200 rural hospitals or so is critical access hospitals. And this is about 60% of all rural hospitals. Others large categories are the sole community hospitals, or SCHs. That's about 16%. And about 1/8 are prospective payment, this IPPS sometimes called. Another 6% are Medicare dependent. So you can hear the wide variety of these different alphabet soups sometimes that we think about these different designations and how important they are. One thing to keep in mind, though, is that one way to think about it is the number of hospitals, where 60% are critical access, for example. They vary pretty dramatically in size, whereas critical access are about 60% of the total number. They're about 1/3 of expenditures. Meanwhile, rural referral centers are about 25% of total expenditures. So they're pretty dramatically different in terms of their size. Now, as we move to the closure question, when we look at the rural closures that have happened since 2005 across the country, and we look at them by type, critical access and PPS have had roughly the same number of closures, just over 70 each. And what that, so clearly, as you look at that, it's okay, PPS and CH are about equal in terms of that. But one thing to keep in mind is, you may remember that there are many more critical access hospitals. And so because of that, the rate of closure for these PPS and Medicare dependent is about triple the rate of critical access. So even though there's just as many, there's more critical access closures than Medicare dependent, when you look at the underlying number, what they're starting from, the rate is much higher for these PPS and MDH, which is a big reason BPAC did this report to talk about this.
More PPS hospitals closing. I did a series on Fort Scott's hospital in Kansas, and it was a PPS hospital, as I recall. And we'll talk more about those designations here in a minute. I know one of the reasons lots of people are tuning in today is because there's so much action going on. Carrie, I was hoping to tap you a little bit of insight to start off with and kind of set the stage for our conversation. We've seen President Trump's proposed skinny budget. We've seen, I think many of us, the leaked HHS budget and reorganization. And now we're hearing about the Medicaid conversations on Capitol Hill today. There's a lot of big cuts out there, a lot of uncertainty out there right now for all of the U.S. health system, but particularly for rural hospitals. With that in mind, can you help us set the stage for why this conversation today is so important with all that context going on?
Sure. Thank you, Sarah, and thanks to the Bipartisan Policy Center for having this discussion and for inviting the team and I here to talk with you. So yeah, as Mark was kind of alluding to with the hospital designations, in rural America, we are really facing challenges that relate to decades of underfunding. And a lot of that is around our hospital infrastructure in rural communities. The report does a great job of talking about the evolution of the rural hospital designations that Mark mentioned. And, if you really think about it, some of the core programs that are in the president's budget that have been proposed for elimination, like the state offices of rural health, the Medicare flexibility program, the small hospital improvement program, those programs all go to support really the infrastructure and kind of connectivity in rural areas so that we can further the work that our rural hospitals do. But they're really a drop in the bucket in terms of the funding need that is that exists in rural areas. And so we think a lot about kind of our rural hospitals being more reliant on public payers. Mark alluded to this, the report talks about this. We have higher rates of coverage through Medicare, Medicaid in the marketplace in rural communities. And so the federal government has a unique role and plays a unique role in preserving our rural providers and our rural hospitals, because in many cases, on average, actually, throughout the country, about 70% of hospital payer mix, or the various payment streams that rural hospitals receive, come from either Medicare or Medicaid. So given that we have rural hospitals that are facing mounting financial pressures, there's rising costs, there's declining populations. We have many, as Mark talked about, that are operating really on the brink of closure. And, if anything, more is needed in terms of thinking, forward thinking, like the Bipartisan Policy Center has done in terms of these designations we have in rural areas. We need to be thinking about how we stabilize these provider types in the long term to make sure that those dollars stay available. Instead, what we're seeing a lot in Washington right now are conversations about how we're making cuts to those public programs. And again, further cutting through the president's budget some of the safety net that's around the larger rural healthcare infrastructure. And so again, this conversation is extraordinarily timely as people really think about kind of some of the policy proposals that are out there to make sure that they fully understand the realm of repercussion that this could have in our rural communities in terms of destabilizing access to care.
Thank you, Carrie, for that. John, I'd like to bring you in right here for the kind of local aspect, if you will. Texas is a big state with a big number of rural hospitals using a lot of different Medicare designations. I know you talk to all of them frequently, John. This is an audience question that was filed beforehand, and I think it really speaks to what Carrie was just talking about, and that is, rather than cuts, over the last years, we've seen alternative payment models that have shown promise for bolstering the financial security of hospitals. What of those models have you seen in Texas, John, that you think are really sticking or working for those rural hospitals?
For sure, and I couldn't have set the table any better than Mark and Carrie did. Our numbers in Texas, we have 157 total rural hospitals. I think that's more than any other state, and they roughly match the distribution that Mark laid out nationally. The program, I think, has promise or holds promise on the very small, vulnerable end of the spectrum is the REH program in Texas, and I think we're going to talk a little bit more about that. We have 4 of those out of 157 in Texas, and it has been protective of those 4. I fear that we wouldn't have had a access in that community had it not been for that new designation. The other demonstration project I'm somewhat interested in is the global budgeting demonstrations. I think they did that in Pennsylvania and Maryland. Those haven't been perfect. I think they can be improved upon, but it's encouraging to me that we're at least trying some new different things. With regard to closures in Texas, we've actually only had 2 in the last 5 years. Both were PPS hospitals. Actually, one was an REH, but that was kind of a Hail Mary, PPS to REH to closure. I used to say that PPS hospitals, rural tweener hospitals, were the endangered species in healthcare. Now I think critical access hospitals are having more and more pressure. We're going to talk about the Medicare Advantage aspects of that. But those 2 things in particular, REH and global budgeting, are the most interesting to me in terms of alternative payment models. And of course, we're trying to find a path to value-based care for rural hospitals, but I feel like we're playing catch up on some of those concepts as well.
Yeah, I'm surprised to hear you mention global budgeting. It's never at the top of my list when I'm thinking of questions about these payment systems. But you also mentioned the critical access hospitals being sort of in danger more now than PPS hospitals. Carrie, how does NRHA view the BPC's recommendation in its latest report to give states more flexibility in designating the CAHs as CAHs, and also if we could talk about necessary provider designation a little bit, I'd appreciate that.
Yeah. I mean, the BPC recommendation is spot on, and it's something that we've been asking for in Congress for several years now. So just as a reminder to the listeners, the critical access designation was created in 1997, I believe, and up until 2006, states could designate a small rural hospital as critical access if it under the necessary provider designation, even if the facility didn't meet all the other eligibility criteria. And we saw a lot of states really recognize the importance of that authority for facilities, and where we really see that is in a distance requirement of 35 miles to the next nearest hospital. 35 miles may not sound like a lot, but when you're talking about mountainous terrain, when you're talking about kind of challenging roads, 35 miles can be a long ways in order to get hospital acute care. And so that necessary provider designation allowed a governor to say, we think this hospital is important to protect, and so we're going to give it the critical access hospital status. That sunsetted in 2006, and 20 years later, we're still kind of operating within that framework, but healthcare delivery has clearly shifted in that time frame. And I think a really good example of this, and Mark could probably speak to this also, is when we first started thinking about this rural emergency hospital designation that the report talks about, and I think we're going to talk about later today, that REH designation, I think a lot of folks assumed it was going to be critical access hospitals who could make ends meet, who were scaling even further down to offer emergency services, but not inpatient care. But what we've actually seen is that we have higher rates of PBS facilities, which tend to be, kind of a little bit larger than our critical access, who are moving to REH to keep that local capacity because they no longer can move under the necessary provider designation for critical access hospital. And that's exactly what the BPC report recommended, is a way for states to bring back kind of a limited authority to do critical access designation. And we've at NRHA have been working with Senators Langford and Durbin on the Rural Hospital Closure Relief Act that would allow kind of that reinstatement of necessary provider designation with guardrails to make sure it's not a full and open kind of wild, wild west, but a way really for the rural healthcare delivery system to be able to right itself as things change, so that we're not stuck in this kind of model from the late 90s and early 2000s.
Mark, the BPC report also points out that many rural hospital designations and/or programs require Congress to reauthorize or renew part of their Medicare reimbursement every few years. What benefit could there be in making programs such as low volume payment adjustment permanent, making some of these designations more stable so they don't have to go back to Congress every few years?
Yeah, so we often like to use household analogies to help us understand government policy. So join me on this journey, if you will. So you live in a house and you got a HVAC that's a little dated and it kind of keeps up. I mean, whether if you want to think it, depending on whether you're in the north or south, it's a furnace or an AC that does okay, but it's either cold or hot throughout the year. So maybe you have like a space heater or a room unit that you can kind of keep going, but you're kind of making do. Like many parts of the country or many people across the country, you're living paycheck to paycheck, so you're barely breaking even. You really know that you need to invest in this new HVAC, but you can't afford it. So what happens now, of course, is that you're paying more every month for an inefficient space heater or a window unit or whatever you need to do to make that work. Now you have some aunt or who sends you a $2,000 check, or you win the lottery or something and you get a $2,000 windfall. Now that's not enough to pay off to build redo your HVAC. So you're like, well, if I knew this was coming next year, see, I'm going to get somewhere, Sarah. If I knew this was coming next year, then maybe I could start this transition to updating my facility or my HVAC here, but I don't know. And so it's another year where I have this, but it's not enough to actually make the transition. So I'm going to continue to pay more every month because I can't, invest in modernizing what I have. So how does this compare to a hospital? Well, many of our rural hospitals were built for 40 beds, 25 beds, 30 beds, and they might have 2 to 3 people on a given night now. that facility is not working for them. They need to update it. It needs to be modernized, and maybe the emergency department is on, a different floor from the X-ray, but they can't afford, because they're barely breaking even, to modernize as they need to. And this is what's happening with a lot of these designations. If the LVH was permanent and the hospital said, okay, this is the new model, I know this is going to come, I can plan on this, I have a budget that I can count on, I can start making these decisions that are looking more than 6 months, a year out, and start thinking about, this is a predictable path and revenue path for me that I can modernize and actually save money and cut my costs by knowing that I'm going to have this revenue that I can count on, this reimbursement, if these models are made permanent. And that we talk about LVH here, that applies to others as well. That so many of these are extended a year or two at a time, just enough to be helpful, not long enough to be able to make strategic planning based on.
Mark, I think if I was a college student, I would definitely sign up for your class. That's a great explanation. REHs have that facility payment, that extra monthly facility payment attached onto them. And I wanted to ask John, since he's got the 4 hospitals out of 36 REHs, that have been designated across the U.S. There are 4, as you mentioned, John, in Texas. And I'm curious if you can talk a little bit about whether you think that facility payment, which I think comes monthly, and they get an annual like dictate of how much that is going to be, if I recall correctly. How important has that facility fee been for those 4 hospitals, and for hospitals considering making the switch to an REH?
It's been everything. I'm down with Mark's analogy too, except, the 4 REHs in Texas, and I think 2 of them may have been the first 2 in the country. They weren't just needing to work on their HVAC and depending on the rich aunt. They were burning furniture to keep the house warm. It was crisis mode, and the REH has been protective in that way. But that's the key to it, is not just a shift to outpatient care and away from inpatient overnight stay, but that predictable revenue stream, budget certainty, where you can plan ahead and not have to ride the seasonal roller coaster of claims. So budget certainty and a predictable monthly payment under the REH designation is critical, and it's everything.
Let me stick with you for just a second, John, from an audience question that was filed beforehand out of Florida. Somebody mentions that at the beginning of the month, their local hospital closed its maternity department after serving the community for almost 100 years. This is a sadly familiar story across the country. It's not saying the hospital closed, just the maternity department closed. What are some of the ways that hospitals and communities can work together to prevent maternity department closures, or even hospital closures?
Yeah, this one's sensitive to me too, because we map, maternity deserts in Texas. And as you go west and north, in particular in our state, you can get 80, 90 miles from a hospital that can deliver your baby. And it's hard to convince young family-oriented people to move to a community where that's the situation and that travel burden is real. You have to shift away from the REH conversation though, because none of these hospitals were delivering babies when they converted. Most critical access hospitals in Texas, at least, don't have obstetrical services. But what's interesting to me is that of the 2 closures we've had in the last 5 years, and then the 22 that we had between 2010 and 2020, none were delivering babies at the time of closure. So to me, suspending your OB program is kind of a red flag top signal of what's in store for you when you aren't able to completely meet that community need, and you give people a reason to leave the community for certain types of care. The way that you can overcome some of the challenges, in my mind, at least if your geography is favorable to it, is some collaboration around physician recruiting, nurse staffing, call coverage, and things like that. Maybe no single rural hospital could support an obstetrical program, but maybe a group or regional collaboration could. And I'm reminded, this is a little bit anecdotal, but a rural hospital that suspended their OB program, I went out to visit him. I said, so how's it going since? And he said, it's terrible. We suspended our OB program and we did save $1 million that day in operational expense. What I didn't realize is that we also lost $500,000 in disproportionate share payments. Our only local FPOB went to the neighboring community and took all of his clinic volume and young, healthy families with him. Our RHC visits have plummeted, and there's no access to care in the county. And it's been a terrible decision. If I had to do over again, I would have done anything to hold on to that OB service. So I always encourage people, to do everything you can before you stop delivering babies.
Yeah, it's striking when the OB service leaves. I was talking to a doctor in Colorado a couple years ago, and he was very much like, we've lost our family practice doctors. We lose so much outpatient money once those close. And I'm no expert, I'm just a reporter, but
Sarah, can I build on John's react to
yeah.
it? I thought it raised two really important points that I just want to make sure that gets lifted up. The first is the importance of a maternity health in particular for the population of a community, and encouraging families to move in or to stay is going to be much more challenging if there's no maternity unit there. The second that he alluded to was the notion that it's all tied together. And what I mean by that is understanding, looking at the maternity unit in a silo without an appreciation of how it's going to play over on other things. And there's a great summit down near you, John, a year or two ago, where they had 5 different hospitals come together and really work through the finances to show how how all these pieces fit together. We've got an example of one of a hospital 20 miles south of here, critical access hospital, that launched a labor unit. And based on this idea that, okay, we don't have enough volume to keep the CRNAs busy all the time, but if they're there for the labor and delivery, they can also help on the OR. And so recognizing this, how it's one piece, and viewing it as a totality of a business strategy. I think, the takeaway I got from that report a year or two ago was that it is more viable than we think if we step back and really look at it. But it just needs to be the supports there at the state and federal level in order to make it increasingly viable.
You fed into my next thought and question, and that is state offices of rural health and the rural hospital flex grants. I was making some calls last week because there's some fear that those may disappear in the coming years. And I wanted to ask Carrie if she could sort of give us lessons to be learned from the REH facility fee, if you will, if in relation to, we've started this REH designation, there are the facility fees coming in. And does that provide any lessons to lawmakers when it comes to talking about the cuts that they're looking at for state offices of rural health and rural hospital flex programs?
Yeah, I mean, I think if you take if taking a step back, I'm going to put on Mark's professor hat for a minute. If you take a step back, if you look at kind of really going back in Medicare, if you look at, we used to reimburse hospitals on something more like a cost-based system. And then in the 80s, we moved to a PPS system, which is the prospective payment, which you get kind of an average payment per service. And that average payment is roughly the same for everyone in the country with certain adjustments. And what we quickly learned in the 80s is that the way that the PPS was calculated for inpatient services and later outpatient services, and then later everything under Medicare, is that those PPS estimates or averages really don't work in a low volume setting, because you got the same fixed costs. It costs me the same to hire someone. It costs me the same to keep my lights on and to buy all the supplies as it does to the larger system or larger hospital up the road who can do twice as many services as I can, but we have the same fixed costs. So we really struggle with kind of that fee-for-service PPS payment method in rural areas. So this concept of, you can call it the facility fee in an REH, you can call it a standby payment, you can call it an anchor payment, you can call it an adjustment, whatever you want to call it. It basically helps to provide some of that continuity of kind of operational capacity year to year or month to month, or however it's structured, depending on the type of payment. Now, that kind of payment methodology, I think, has got a growing popularity. And I think REH is kind of the first place that we've really seen it, but we've heard that conversation on a lot of different other kind of potential future models. We also talked about, and John brought up kind of the value-based payment piece and that movement towards value-based care and participation in kind of those quality reporting systems is a really important piece. And we've seen in the Pennsylvania rural health model that we really were able to improve health of the participating residents or individuals living in Pennsylvania while helping to kind of maintain access and shore up the stability of the rural hospitals that were participating in the demo. But that was a demonstration. It has since ended, and most rural providers are not ready to move directly into kind of that value-based model where you're getting kind of paid for the outcome of the service and not on every single service you do. And again, I'm getting to a point here in that the programs we have through the state offices and the Flex program, they are critical technical assistance and kind of facilitators to help rural hospitals get to where they need to be to participate in value-based payment or population health. And the Flex program has a proven track record of this. They have specific initiatives that states work on that help to bring critical access hospitals into CMS quality reporting, adoption of value-based models, providing dollars to help with data transparency and benchmarking and peer learning and all of the things that critical access hospitals and small rural hospitals need to do to be able to participate in value-based care. And we've seen the percentage of critical access hospitals nationally grow in accountable care organizations and other payment models based on kind of that support that they get through the Flex program. So again, as we are talking in this report, and as we talk broadly about where rural health needs to go, it needs more facilitators like these programs to get us where we need to be as a broader rural healthcare system. And instead, the conversation that we're having, at least right now, at least what we've seen in the leaked president's budget is actually taking a step backwards from that. And so, all of these innovations we've made, I think are at risk in terms of if we'll be able to continue them in rural communities.
Yeah, and then just to sort of bring it home in my mind, when I think about the state offices of rural health, I think they're sort of nebulous for a lot of people. Maybe not everybody on this call, but for a lot of people, they don't know about them. They don't know what they do. They don't know that they administer the Flex grants. But also when John and Mark talk a little bit about that community and finding the right mix for those communities, it seems like from my interviews, that state offices of rural health can help with that. And if you just eliminate them because nobody knows about them, you don't realize what you're missing out on.
Yeah, that's right. And the other thing about the state offices is that they are, again, kind of facilitators. Not only do they connect in terms of information sharing and building capacity in rural communities, there is a 3-to-1 match for all federal funding coming in to the state office, to a state from the federal government for a state office of rural health program has a 3-to-1 match. So the state is matching it, times 3. And in many states, we've seen just incredible capacity built in the broader rural healthcare infrastructure through bringing in other federal grants for doing public-private partnerships. The state offices play that role in that as a connector in that way. And it is a little amorphous to try to get your head around, but man, it is just essential in our rural communities. It's really, really hard to imagine rural healthcare without those folks in every state.
Yeah, and then just to sort of wrap up this section to talk about something else really essential, because it is sort of the big white elephant in the room, if you will, or the elephant in the room, and that is Medicaid funding, right? It's being discussed right now, or this afternoon, I guess, later on Capitol Hill. And we know, I think we all know that nearly half of all births at rural hospitals in 2023 were Medicaid, and that the ACA expansion has shown that in states that expanded Medicaid, those hospitals, particularly rural hospitals, are more financially stable. I wanted to ask each of you to talk just quickly what advice you would give to lawmakers as they look at trying to cut sections of Medicaid right now. What advice would you give? Carrie, you can start.
All right. Well, as I mentioned kind of earlier in the program, rural areas, folks who live in rural areas are more dependent on Medicare, Medicaid in the marketplace. So without intending, maybe, if you are cutting Medicaid, you are disproportionately impacting rural America. And whether those are kids, adults, older adults, disabled communities, we have higher percentages of rural population enrolled in Medicaid. And it's not just the individuals who are covered by Medicaid. It is the reliance of our rural hospitals, our rural providers, skilled nursing facilities, rural health clinics, you name it, on having those individuals in their communities having insurance coverage through Medicaid. And if you lose that, we've already talked about how so many of our rural hospitals are operating on, if not negative, which almost half of the rural hospitals in the country are operating on negative margins, they are operating on razor thin margins. So if you're cutting Medicaid, not only are you implicating or you're impacting the individual who receives the Medicaid, you are impacting the facility who's caring for those people. You also are impacting the whole community who's receiving care at the facility. And a great example of that is as rural hospital budgets tighten, and as you maybe have a year where you do have negative operating margins, you have to make some tough choices about what you're going to offer in your facility. And the conversation we just had on obstetric care is a great example of, it's a quote unquote optional service. We could get rid of it and still keep our doors open. And those are some of the tough choices that hospitals are already having to make, that if they're further squeezed, I think we'd see more and more of that. And that impacts, again, not just the individual who is on Medicaid, but everyone who is receiving care in that rural community. And I don't know that those connections are always made by policymakers as they're thinking through kind of the nuance of the various options.
So your advice would be, please, policymakers, really understand the impact of Medicaid on the rural
Yes,
communities.
absolutely.
What about you, John? Any advice to lawmakers on Medicaid?
Well, the advice I've been giving selfishly is cut the match in expansion states and leave non-expansion states like Texas alone. And clearly that did not work when we saw the makeup of the E&C committee or the markups that have been released in the last couple of days. But Carrie's right, just by virtue of rural demographics, the Chamber of Commerce directors don't love it when I say this, but rural communities serve older, poor, sicker populations, and there is no room to absorb cuts. So when, I think the CBO didn't completely finish with their work, but their estimate is 13 million more uninsured Americans by 2034. That's going to be more rural in terms of the percentage just by virtue of rural demographics. And I don't know what that's going to look like, but it's going to hurt access to care in rural communities. And Dr. Correct mentioned this at the top. Access is important. The thing that I try to talk to lawmakers about that I think is equally as important is rural economic development. And those hospitals are anchors of economic development in the community. They not only provide good jobs, but there's a clinic tied to it. There's a pharmacy tied to it. When you see a rural hospital close, you see the grocery store close and the pharmacy close and the bank close. And you go back a couple of years later and literally the entire community has fallen down. And you realize in some ways it was that rural hospital that was lifting the community up. And so I'm scared to death of the consequences of what we're debating this week.
Yeah, people lose Medicaid in rural areas. They often just are charity cases at these hospitals. Mark, any quick advice you would have on the Medicaid topic right now that's hot on Capitol Hill?
Just taking John's point a little bit further, and that is we've done a couple studies on exactly what happens to communities after a hospital closes. And it's, as he mentions, income across the board goes down, population decreases, unemployment goes up. These are, usually the largest or second largest employer in the community. And so understanding how health and economic development are tied together, it can be really important.
That's right, Mark. And in terms of quality and outcomes, the other thing that studies show is that mortality rates go up in rural communities that lose their hospital.
Yeah. the BPC report, because that's one of the reasons we're doing this today, rightly looks at Medicare Advantage. I know I'm switching back and forth from Medicare designations to Medicaid, but now I want to talk about Medicare Advantage for a moment because we know that that is really growing in rural America. The membership of Medicare Advantage enrollees is growing in rural America, and overall, it's more than 50% across the country. And John, you're being so animated right now. I want to ask you, are there specific examples from your members that illustrate sort of the issues of the challenges with MA plans, such as, prior authorization? I've heard about prior authorization. I've heard about limited networks. Do you have any kind of anecdotes from Texas that you can share? What's happening out there?
Well, I have lots of them with trying not to get too animated or too geeky or technical. I'll tell you that the reason I'm starting to worry more about critical access hospitals than I did the tweener PPS hospitals in terms of vulnerability or survival is the proliferation of the MA plans. And in my mind, the prior authorization issues, the denial issues, that's universal. That's not rural versus urban. It's the same. There might be less rural resources in terms of the administrative requirements of that would have a disproportionate outcome, but rural's in the same boat. What's specific to rural in my mind is the cost reporting and cost settlement that's available to critical access hospitals in traditional Medicare, but not Medicare Advantage, and the denial rates we're seeing among the Medicare replacement products that really outrun traditional Medicare. With regard to anecdotal story, the one that gets me the most fired up was in Denver City, Texas, and they had a guy that needed some wound care, needed to swing him, couldn't keep him, couldn't get the authorization from the plan, so they discharged him to home. The next day he fell and hurt himself, came back to the hospital, was transferred by ground ambulance to a larger tertiary hospital and passed away, unfortunately. And then the following day, the hospital received a letter from the plan that said, we've reviewed that case and now we can authorize the wound care swing bed admission. And it just was tragic because it was too late. And so stories like that, even though they're anecdotal and not too common, thankfully, they illustrate the problems with the program for critical access hospitals in particular.
So please.
That's it.
Okay, I thought I heard somebody else chiming in on Medicare Advantage, but let me just sort of follow up exactly what you were saying about, the rural hospitals often don't have huge office staff available to negotiate and debate the prior authorizations with the insurance companies. Oftentimes you have to go back to the insurance companies and file, my understanding. And larger health systems tend to have larger staffs too. In the BPC report, it notes that discrepancy between traditional Medicare payments and MA are particularly straining, the smallest critical access hospitals. And it also suggests shifting MA payment negotiations for critical access hospitals, shifting those payments to Medicare administrative contractors. I've never seen this idea before until reading the BPC report. So I'm curious if any of you, I'm thinking Carrie, John, Mark, any of you could share thoughts on that strategy of shifting over to Medicare administrative contractors. Is it feasible?
Well, I can jump in there. I mean, I think it's definitely worth exploring. The challenges, I think there's a couple of things that may be able to address. One, the piece that John was talking about, we really, as we've talked about the last 45 minutes, we have worked long and hard to try to get some of these alternate payment methodologies like critical access hospitals established and under traditional Medicare, and under Medicare Advantage, plans don't have to pay that, right? They don't have to do cost settlement. And, one of the things that we're really advocating for is a policy change that would get our critical access hospitals, our rural health clinics, our other alternate providers back to those traditional Medicare rates. And I think that, working through whether it's cost settlement on your cost report or another methodology, I think that's a critical part to the solution here. In terms of having the MACs play that role, I think one of the other things that John talked about is that the delays in payment, I think, are similar to what lots of folks are having to deal with across the board, but the uniquely challenging part for rural is what John said. We just have less of a cushion at the end of the day. So there's fewer resources. We don't have the days cash on hand if a plan decides they don't want to pay me for 180 days or whatever. And so the thing that's very attractive about moving to the max is that you have kind of some of that stability that you would have under traditional Medicare in terms of how you cost settle or how you get your payments made to you. But I would say that, some of these other policy changes we're talking about would need to go along with that. So things like payment equal to traditional Medicare, dealing with prior authorizations and delays and denials of services. And then again, coverage of certain services like your swing beds that are really unique to rural areas that Med-May plans aren't required to deal with. And as a result, really nobody wins. And most importantly, the beneficiary loses, because either the hospital's taken on a patient and not getting paid in a way that's going to make them whole at the end of the day, or the plan is denying care, or the hospital isn't taking the plan and the patient is having to go somewhere else. So we're really in kind of a no-win situation right now, and I think it is an area that's ripe for change.
Sarah, let me jump on there, and I agree with everything Carrie said. It's the cash flow crunch that rural hospitals face that puts additional pressure on them. And this may be somewhat anecdotal, but the rural CEOs that I've talked to, say contract negotiation is not my forte. It's not what I do. I don't have an internal resource to help me negotiate those agreements. And even if I did, at the end of the day, even if I know it's not a great agreement, I can't stand the thought of a local retired teacher having to go to a larger city because I'm going out of network intentionally. I'd rather try to figure out another way to survive than deny care to that person. So that creates a real disadvantage. I haven't spent a lot of time thinking about the MAC approach, but I'd be open to it simply because it seems like a way maybe to work together on behalf of all rural, rather than trying to build a muscle that doesn't exist.
I'm curious, I want to bring Mark in for just a minute because he has been watching hospitals for a long time in rural America and their struggles. And I'm curious, Mark, as you've watched the growth of MA, particularly in rural areas, how do you think, maybe it's not the max, maybe it is asking for help with negotiations, but are there any other steps around Medicare Advantage and the growth in rural areas that you would suggest lawmakers look at from a national level?
I mean, there's a common theme today has been predictability and cash flow, and we've heard that multiple times, starting from question one, I think. And so addressing that will be really critically important as MA becomes larger and larger component for rural hospitals. If we think about 30, 40 years ago, if the primary policy lever that the federal government had to influence rural hospitals or rural health more generally was Medicare through inpatient. And as rural hospitals become less and less of an inpatient provider and moving more towards outpatient, and Medicare gives way to Medicare Advantage, which, as you've heard from both Carrie and John, is a pretty completely different animal. It has the same word in it, but Medicare Advantages are commercial. And so they operate much more like commercial plans than Medicare. And it changes the nature of how, 4 decades of federal policy to shore up rural health has really operated. And REHs are one step in that direction. But then again, the critical access hospital, which has proven to be highly successful in keeping access to hospital services in small and isolated rural communities, that gets harder as Medicare Advantage, takes away from the traditional fee-for-service Medicare that is the linchpin of how a critical access hospital works.
So you're thinking predictability and making sure that people know what's coming down the road when it comes to Medicare Advantage. We are 10 minutes out from the end of this, and I know that the BPC report also covers another essential part of rural access and care, and that's the rural emergency medical services. I think that there are some people in the audience interested in this. I just wanted to add an anecdote to this. I've been hearing about the challenge, and we've written here at KFF Health News about rural emergency management services and the challenge they're facing with staffing and finances. I was in Greene County, Alabama for a recent story, and I walked across the street from the hospital to the EMS service. And I just wanted to make sure I understood what was happening with a certain patient I was writing about. And they said that, well, we've got 2 ambulances working. I said, well, how many ambulances do you have total? Well, 4, but the 2 of them are in the shop and they haven't been working for a while. And I'm like, so you have 2 ambulances for this entire county? And the answer was yes, of course. And I don't think that's a unique situation, but it was just very, I mean, this is literally sitting across from the hospital, and if both ambulances are transporting out of county, then there's no ambulance in the county to respond, right? And I know I'm saying something everybody knows, but the current state and challenges when it comes to rural emergency medical services are very unique. They're the workforce shortages, they're long response times. I wanted to kind of kick this back to John and ask what the most pressing EMS issues in Texas are and how they affect the hospitals that that are part of your membership. What are you hearing kind of as the most pressing issue?
Well, who pays? Rural emergency medical systems, ambulance services, in Texas at least, almost always have to be subsidized in some form or fashion. So it becomes a hot potato issue with the local hospital or the county or the city, at least in Texas. And those become very tough conversations around taxes and things of that nature. But the thing that also adds to the vulnerability is the geographic isolation of some communities, that travel burden that's associated with it. One unexpected, I probably should have anticipated this, outcome of the REH designation is, all those historically inpatient admissions are now transferred to the cities. That puts more load on the ambulance service. You mentioned going to Alabama. I went to a rural hospital closure in Trinity, Texas a couple weeks ago. Would not recommend it. It was awful as they locked the doors and covered up the ER sign. But I talked to the local EMS service, and they said, we aren't sure we're going to be able to survive because in the time it takes us to do a ground transfer to Huntsville, which was the closest city, we could do 4 local 911 calls, but we aren't going to be able to do that anymore because nothing goes to the local hospital that's closed. So all of this uncertainty, to borrow the theme, and closure crisis reveals itself in a lot of ways on the EMS service.
Harry, the temporary add-on payments for rural ambulances are set to expire. I know you guys have lobbied on this. Can you talk a little bit about where that stands and what reforms or demonstration projects would you recommend to lawmakers on the rural EMS right now?
Yeah. Well, as Mark talked about, we've got a handful of designations under Medicare that are aimed to support rural, and EMS and Medicare dependent and low volume hospitals frequently get dubbed as the rural extender package. So they're usually all in the same boat. And as Mark talked about the predictability being a challenge, I mean, man, in an ideal world, if we can't make these things permanent, we ask for a 5-year kind of extension. The last 2 extensions have been 3 and 6 months. So that gives you a sense of where we are right now. But all of those extender payments, including the ambulance bonus payment for rural and super rural, I kind of love that they call it super rural. We don't get to use the word super very often in our rural healthcare conversations. So our super rural bonus payments are set to expire at the end of September. So we are looking for advocates to help us lift that up and make that a longer term extension. But, when we talk about EMS and when you talk to EMS providers, I always mention the ambulance bonus payments and they're like, oh yeah, that's nice. But so much more reform is needed in this space. And Sarah, you hit on all of the kind of critical areas. We really need to be looking at how we pay ambulance services in a way that allows them to maintain the capacity for all of the equipment and other support needs that they need to do, especially in rural communities where those rides are so long. So there are proposals out there that would allow, and when I say proposals, I mean pieces of legislation that would allow Medicare reimbursement for EMS care provided at the scene, regardless of whether or not that individual ends up being transported back to the hospital. So when folks are going out, they're for sure receiving a reimbursement at the end of the day for that care that they're providing in the home or whatever they're doing. So that's one. There's another concept of allowing kind of a treatment in place, especially if you think about like our older rural residents or homebound individuals, allowing Medicare to do at-home emergency medical services for minor incidents, obviously not things that need acute medical condition or attention, but giving reimbursement to allow for some of that care provided in a home setting, that both saves the patient from being transported, but also then makes that service a little bit more viable, because they might get called anyway, but may not get, the reimbursement at the end of the day. And then in the workforce side of it, I really think, there's the concept of community paramedicine that's been around for a long time. The thing I love about this idea is that you take these healthcare professionals, these EMS or paramedics who have the capacity to provide services, may not be used all the time, but when we need them, man, do we need them. And the paramedicine idea allows those individuals to have funding to be able to do kind of preventative local care in communities, going to homes and other settings, and get reimbursed for that when they're not doing EMS services. So it's another kind of innovative way that we support this workforce broadly, without kind of limiting their capacity. Because in rural areas, you said, we're more reliant on our volunteers and unpaid workforce. We are strapping things together with duct tape, and we really need to be thinking creatively about how we're supporting the workforce and the services themselves.
So I have one more sort of detailed policy question before I want to ask you guys a final parting question, and that is about 340B. Yeah.
I
So
call that it.
we've talked a lot about programs, funded by Medicare, Medicaid. 340B is sort of an outlier. It's always a fun topic to talk about. I'm kind of curious, outside of Medicare hospital designations, are there programs like 340B that are impactful that we need to kind of address when it comes to rural healthcare that you might say are beneficial for sustaining care in rural communities? 340B, is it beneficial? Are there other programs outside of the Medicare designations that we've talked about today? And of course, Medicaid that I'm missing that we need to address?
I'll jump in there. 340B is definitely beneficial. There are a lot of coverage of some bad actors in the program, but I would challenge you to find one that's a rural community provider. I think most rural communities are using the drug discounts as intended. When you step away from that for similar examples, we're big fans of workforce programs, physician and nurse loan repayment programs, National Health Service Corps, things of that nature. But I fear that those could become the target of federal budget cuts as well.
Well spoken, well spoken. And since Carrie already begged off on 340B, which I understand, I won't, Mark. I will switch gears. I appreciate that, John. Thank you so much for the candidness. I know we're running out of time, so I just want to give each of our wonderful panelists a chance to talk about kind of parting words, on this conversation today. Why is it so important to talk about these rural payment mechanisms in hospitals when there's so much going on in our national conversation today? Why is it important to talk about rural America and its healthcare right now? And Mark, can we start with you?
Start with me. Okay. Well, I think that it's important to recognize that we are one nation, and I'm going to wave a flag a little bit here, but people who live in urban areas may not understand the importance of rural, but that's where our food often comes from. That's where a lot of our fuel comes from. I've been on a tour of rural hospitals across the country with my kids on vacation as they cut their feet on this or that or the other thing. So the important part of rural health is that we often need it, and healthcare needs to be local to where you are at the time you most need it. In North Carolina, we talk a lot about the people from the west side of the state who are being seen for a jellyfish sting because they're at the beach on their July vacation. So understanding that our healthcare system needs to be strong everywhere, I think is the way that I sort of think about this conversation.
Yeah, I'll let Carrie back clean up and go right now, and appreciate Mark's patriotism. The only thing I would add to that is, rural matters, and even if we can agree that conversations about austerity and budget deficits is overdue, the impact of those decisions is going to reveal itself in rural first, and I'm scared of what that's going to look like. And then the other point, I mean, I don't, it's not just where you get your mail. I'm in Dallas today, and if something happens to me, I'm an urban trauma patient. But most metropolitan Texans drive through rural pockets of the state or send their kids to camp in rural parts of the state, and access matters for them as well. I suspect that some of those jellyfish bites on the beach are from urban Americans who are on a vacation. So it's not just a rural conversation, especially when it comes to trauma systems. It takes everybody, and we've got to work together to find solutions on these things.
Yeah, and I think just, to wrap it up, building on that, and we've talked about this throughout, this is all interconnected. Whether you're living in an urban area, driving through a rural area, or whether you're a rural patient and you get sick and you don't have a hospital and you need to go to that upstream urban facility, it's all interconnected. And as we think about these policy proposals that are out right now in reconciliation and the president's budget and the great work that the Bipartisan Policy Center did on their report, is you make little shifts here and there, because the rural infrastructure is held together with duct tape and good wishes, man, it is a fragile one. And I think it's just really important to think about how we stabilize that, how we shore it up, and really how we innovate and get people the quality of care that they need to address some of the current health outcomes we have, so everyone, whether you're in a rural or an urban area, can live a good, high quality life.
Thank you so much. And thank you, everybody, for staying for the hour and listening to this. We moved pretty quickly. I will say that BPC's reports, both the REH one and their latest one, are up online. I would also say, if you have any questions about rural America, definitely check out the websites of UNC Sheps Center. And of course, NRHA's website has lots of resources on it too. And then just to sort of wrap it up, I know we focused on rural America today. That's what the BPC report is. That's what we're experts on. But really what we're focused on are patients, period, right? Like I like to go out and talk to people and patients and hospitals, wherever they're at, and learn about the healthcare system. It's all one big healthcare system. But yeah, thank you so much, Mark, John, and Carrie, for lending your expertise. We covered a lot of stuff. The reports are up online, and have a great day. Thank you so much.